Bridget Teven with your online lecture for management and leadership. And during this time, we'll look at both of those things, but also common sources of conflict and how to resolve those. Communication, not only during conflict, but in general with your peers, with physicians, with your manager, the chain of command, and your communication that's reflected in the medical record. We'll take a peek at risk management and quality improvement, as well as the performance appraisal process. So what is the difference between a manager and a leader? I'm not going to read the whole slide to you here, but please note that the differences between managers and leaders is not about power and control, rather that of influence and inspiration. We're going to start off here with looking at roles, assignments, and the process. You will be working underneath a manager on the unit level, and then there's also a director or someone that manager reports to, on and so forth. We're going to be looking at teamwork, conflict resolution, stressors and burnout. Lots of things here over the next several slides. The one thing I will say though about conflict resolution is it's important to speak to the individual directly involved first before escalating it then to the nurse manager, the director, the vice president, a committee if there's one appropriate for the situation, or human resources. You'll find that the majority of facilities have a policy written about how to handle conflict, and they want you to really handle that at that local level first. With assignments and delegation, someone like a clinical supervisor or the charge nurse on the unit for the day will be the one making the assignments. But the difference really with assigning care versus delegating care is delegating care has to be a task that's appropriate to the qualified personnel, looking at their credentials and their licensure. When the charge nurse is making the assignments, there's many things for them to consider. Pre-assigning considerations such as the client's need, their acuity of care, how heavy of a load is it? You don't want to have a nurse that's drowning. You've set her up for failure at the beginning of the shift because you gave her 4 patients that are total care with tubes and drains and trachs and a gazillion meds and 3 IV lines and a feeding tube and so on and so forth. Meanwhile, you give somebody else an assignment that all their patients are what I would refer to as a walkie-talkie, meaning they can do all their ADLs for themselves, they answer you appropriately, all their meds are oral, they have no drains or tubes or anything of that sort that require extra skill and time. So really have to consider all those things. Also, that person making the assignment should think about how can I best avoid disruption to the normal workflow when I'm making these assignments. Now, it also doesn't make sense for you to have one patient at the far end of one hallway, and then you have to walk clear back up that hallway, down the corridor, and then to the very end of another hallway. You're wasting so much time with travel back and forth. So while they'll try to cluster your patients relatively close, they have to consider not only that, but again, the acuity, the work involved to care for that patient appropriately for the day. While you're caring for your assigned patients for the day, you have to keep in mind everything that needs to be done and do them according to policy and giving the best quality, safe care that you can for the patient. You think about the legal aspects that are involved in all of that. Liability is the legal accountability for client risk, danger, and injury caused by a nurse's malpractice of negligent acts. And negligence involves either acts of commission, which is doing something that harms the patient, or omission, which is not doing something that should have been done to prevent the client from harm or injury. So when you receive your assignment for the day, you're looking through the list and you're thinking, oh, I don't know if I really can do this. I don't know if it's manageable. Is the load too heavy? What's going on? And so when you're having those thoughts and you're kind of feeling like, I don't know if I can do this, you need to assess the situation carefully and have that based on facts, what is actual, what is really going on with the patient, what does it really entail. It can't be based on opinions, but you want to speak to the supervisor about it, and again, state the facts of why you don't think the assignment is manageable or fair, but be willing to listen, be open to other suggestions or alternatives. Be willing to offer an alternative to potentially change that assignment. Big thing is don't jump to conclusions without exploring all the avenues and all the possibilities of a different assignment. Make sure it's based on facts, not a scenario of what if X, Y, and Z. It needs to be based on facts. And most importantly, do not leave. Once you have accepted report and agree to the assignment and leave the unit, that's patient abandonment and you can lose your license. You don't leave. Go to your supervisor, talk it through, be willing to listen, be willing to explore other options. And again, it needs to be based on fact. In any institution, teamwork is an expectation. This is accomplished through helping each other out and not having the mentality of, well, it's not my job or it's not my patient. Hourly rounding by nurses and technicians is a good example of teamwork. Typically there's assigned times that nurses will round versus techs, and keeping that communication between both parties open really helps your day go a lot smoother. There's also huddles at designated times on the unit addressing patient discharge condition, discharge status, home needs, current needs, changes in condition, anything like that. Also, part of teamwork is having a good bedside report for the offgoing nurse and the oncoming nurse to visualize the patient, current IV lines running, the patient's mental status, things of that sort. So this is all good examples of teamwork. It really is essential to making your day run smoothly. I'm not sure that I've ever worked somewhere that there hasn't been conflict to some degree. Maybe not, involving every single person on the unit, or there's just conflict. There's conflict. It's a disagreement between individuals or groups based on differences in their interests and attitudes and temperaments, as you see here on your slide. Some reasons for that are listed here as well. Lack of trust, poor communication. Sometimes it's just somebody doesn't fully understand and they draw a conclusion, and really it's not the message that the sender was trying to achieve, and so just talking it out. But anyhow, with conflict, there's negative conflict and positive conflict. So some symptoms of negative conflict are complaining, having a demoralizing attitude, violence, missed or ineffective communication. I just touched on that. Having anger or frustration. And when we think about symptoms of positive conflict, we're thinking about providing impetus for change, helping to understand other jobs within the unit or job roles, opening up communication channels, energizing people, redistributing resources, things that could help the unit as a whole. So with conflict resolution, communication is a most important part of that. You've got to talk to each other. And like I said before, you want to talk to the person directly involved first. Now, if you look through these steps here of identifying the problem, generating possible solutions, etc., it looks to me an awful lot like the nursing process we use when we assess and then we plan and implement interventions, etc. So it's important to follow these steps and hopefully be able to resolve this the first go around. With stressors and burnout here, there's a couple things to think about. If you have a stress alarm, that's the body's initial response with a slight decrease in resistance to a trigger. Now, your stress resistance is when the body makes adjustments in effort to restore balance because it knows that something else is going on. And stress exhaustion is when that resistance continues to decrease and an illness can occur. Most of us have probably had an event in our life that has really stressed us, and then we end up just having an upset stomach, or we're suffering with a headache or something of that sort. So when you look at these stressors here, physical responses to stress, increased heart rate, increased blood sugar, dry mouth, these are sympathetic responses. On this slide here, you'll see that you have different triggers of stress, stress relief options, stress management options, and then implications of burnout, whether it be financial, physical, emotionally, or social implications. So we just went through stress and burnout, and now we're going to start talking about communication. But you know, sometimes truthfully, communication can be stressful. If you're not sure how to approach someone about a given subject or something that makes you uncomfortable, that actually could be a stressor in and of itself. But communication is the core skill for nursing leadership, but it's also important for each one of us with our peers. It is inherent in all communication exchanges that there is a sender, a message, and a receiver. So we have verbal communications, peer-to-peer, nurse to physician. We're going to talk about telephone orders, patients and families. That can be pretty stressful as well. And also our email communication. But don't forget, we're going to talk about medical record communication too. Calling the doctor. This creates stress for some people. When determining if you should call a physician, ask yourself, do I have all the information that he or she could ask for during the call? Can I consolidate a call and ask about more than one matter or more than one patient during the time? Or maybe do some of my peers have to talk to that same physician about a patient they're caring for at the same time? We can consolidate those phone calls. Don't apologize for calling though. And if you need to call the physician and leave a message, make sure you notify the unit that you're expecting a return call. With the Halo phones that each individual nurse carries now on our units, it's not as big of a deal, but you might end up working somewhere that not every nurse is assigned to a direct phone line that he or she can carry throughout the unit. So make sure the secretary or whoever's at the desk knows if you have to leave a message and you don't have that phone they can call you directly back on, that you are expecting a call from he or she, and you want to have them be able to connect you as quickly as possible. When receiving a verbal order from a physician, you need to listen carefully and you need to make sure that you're reading it back for clarification. Now, we want to do this very sparingly, and orders verbally should only be taken by RNs or LPNs. But when you're listening to that, don't be afraid to speak up. You should feel comfortable in questioning the orders if they don't sound correct to you. You should have a working knowledge of the drugs and dosages and other therapies, treatments, tests, etc., that would help you meet the needs of your patient. And if it doesn't sound right what the physician has ordered, you need to speak up. You are that patient's advocate. Be very careful with your email communication. It should only be used for work-related matters. And don't send anything that you would not like posted on a large movie screen in the courtroom if it's brought to litigation or the front page of a newspaper. Be very cautious. So the medical record, really it's the keeper of all things related to the patient. Your communication in the medical record needs to be appropriate and professional. The purpose of this is to serve as a basis for patient care, continuity of care, documenting evidence, and communicating between clinicians. It is important that you record everything in a timely fashion. The accuracy and completeness of this might be questioned of you during a legal argument. And risk management will tell you that the best defense against a malpractice claim is completeness, objectivity, consistency, accuracy, timely, and legible charting. Okay, your documentation within the medical record. There's a lot to cover here. Paper versus electronic. Now, pretty much everything now is electronic. However, when there are scheduled downtimes or even unscheduled downtimes and the software decides to take a little nap, you need to be able to document everything appropriately and accurately on paper. Sign your notes. Every single entry you need to sign. With electronic charting, it's not as much of an issue, but you must always sign into the computer under your name before you document. And likewise, don't allow someone else to chart underneath your open computer. That's why we are so strict about making sure that computer is locked to protect yourself, but also to protect your patient's privacy. You don't ever want to walk away or allow someone to document or read underneath your login. So always sign in underneath your name and always sign out, and that will electronically stamp that you are the one that did that documentation. You're responsible for charting. You're responsible for charting underneath your login, and you're responsible for logging out. Countersign only when it is needed for verification. Let's say insulin medication administration. That's the only time you're going to countersign, really. A record of time is kept electronically for all entries. For when you notify the physician, for when the physician has posted new orders, securing consents, authorizations, release forms, order changes, everything. Protect yourself and make sure that you stay on top of all communication that's in the computer. And also protect yourself by never altering the medical record. When you're doing paper charting, don't ever skip lines, okay? If you make an error and you're doing paper charting, it's a single line through the error. Never obliterate. And use ink when you're doing paper charting, like for downtime forms. Abbreviations, they should be used sparingly and only from the formally authorized abbreviation list by your institution. Right now, there's over 1,400 approved abbreviations in the Atrium database. You need to really be careful with abbreviations too, because some of them have dual meanings, such as C, like Charlie, X, like X-ray, CX. It can mean cervix, or it can mean circumflex, like the artery. So be very careful, use abbreviations sparingly. Now, when it comes to actually documenting, you need to document what you see, hear, smell, feel, and subjective complaints. So objective charting is a must. You must avoid conclusions. You must state specifically what you see, hear, smell, and feel. You want to avoid using words such as unintentionally, inadvertently, somehow, unexplainable, unfortunately, apparently, things of that sort. And do not speculate or give your opinion. There's some examples here about subjective versus objective. As I mentioned before, not only logging off the computer protects yourself, but it also protects our patients. That record should be confidential. Physical security of the medical record by logging off of the computer. And don't leave any papers on the cow in the open hallway. Removing records. Don't copy records. I know a lot of people want to copy the med list or something of that sort just to make their workflow go easier, but really you shouldn't be copying any part of it. It's too easy of an error to put something in your pocket and then take it home with you, and that's not appropriate. You do not take home shift report sheets or anything else containing patient information. So if you don't print it, that reduces the error of that happening. Records release, medical records usually handles this. There's specific forms that have to be filled out, permissions given, etc. So you will learn in your orientation wherever you take a job about the process for that. I already mentioned about don't copy the med list, don't copy a shift report sheet. You will have some sort of an organizational tool that you use. Sometimes I'll see somebody put a sticker, a patient sticker on there. And that may be okay by your unit or by your facility, but it has to go into the secure shred bin if that's permitted on your unit. That has to go in the secure shred bin before you leave. You do not want to take any of this stuff home with you. And really, do not get into a chart unless you're assigned to that patient because you're curious. It's a neighbor, somebody you go to church with, a VIP. Just out of curiosity, oh, I just want to look and see. No, that is not appropriate. You have no right to be in that chart because you're not assigned to care for that patient. That chart should be kept confidential. So the medical record, when it comes to admission, discharge, and teaching of the patient, here's some best charting tips. I'm not going to read that whole slide to you, but like when you're thinking about charting the patient's discharge, you want to talk about the diet that the patient's going to be on, the activity or restrictions of activity, rest periods, exercise programs, hygiene, about cleaning around an incision or something of that sort. If they're going home with a Foley catheter, colostomy care, any follow-up appointments they might have, or therapy appointments, any agency referrals that they have been given, that should be documented as well. Medication reconciliation list, send them home with that. The name of the drug, the reasons for taking it, the dosage, the frequency, and side effects. Now, be careful too when you're documenting the medication. Sometimes the patient's accustomed to the generic name. Don't be giving them something with just the brand name only, and then they're going to be confused about what that is and where is the one that they're accustomed to taking because they don't see it on the list. So just be careful about using brand versus generic names. With AMA, against medical advice, that's when a patient has seen the doctor but refused the treatment or the admission. It's elopement of a patient, or they left prior to the discharge process. You need to make sure that that all is documented. Risk management is another big area when we're talking about the care we're providing for patients and keeping the medical record. Some common allegations against nurses are failure to interpret and follow doctor's orders. Lawyers love that. Report questionable care or substandard medical practices, and failure to monitor a patient, implement safety measures, or failure to document the care. There's a saying that if it's not documented, it's not done. And you could say all day long in a courtroom, but I did it, I did it, I did it. And they're going to say, there's no proof that you did it. It's not documented. And they might even look at some other charts that you have documented on and say, well, you documented this here, so you must have done it. But here you didn't document, but you're saying you did it. How can we believe? Because if you're telling me you document all the time when you do something, then to me, you didn't do it because you didn't document. You went against exactly what you say that you do. So you don't ever want to be put in that position and have to defend yourself. Attorneys look for omissions in charting, contraindications, and inconsistencies. Time delays between a physician, let's say, writing an order and you actually reading the order and implementing whatever the new action is to be. They're looking for time gaps. Alterations or appearances of alterations, lack of supervision of the patient, not receiving informed consent, or lack of education for a patient. You know, when you're given a medication, a lot of times it pops up and says, hey, go to the education teaching record because the patient's never received this medication before. You need to teach them about it. So those are things that the lawyers would look for. When it comes to documentation of emergencies, doesn't matter if they occurred in the operating room, the emergency department, in the ICU, it must be documented by minute, from the onset of the crisis, medications that were given, treatments that were done, procedures that were performed. That is incredibly important. And we talk about this in codes. You know, somebody is assigned to be the documentation person. We have to know, you know, when meds were given, when they were intubated, how long CPR was going on, when they were defibrillated. So documentation of emergencies is a minute-by-minute deal. If you have an instance where you need to correct a medical record, again, I mentioned this earlier, if it's on paper, it's a single line through the air with the date and time and your initials. You do not want to write things beside there, such as error, mistake, wrong dose, things like that. That's kind of incriminating. Just draw the single line through it, date, time, and initials. You want to enter the correct information then in chronological order, okay? And if it's questionable situation, have a witness co-sign that with you. Workplace safety, another big area that we need to talk about. I'm going to touch on a few of these here. You see many things listed. Bioterrorism, that's really the use of microorganisms with the deliberate intention of causing infection to achieve a political goal. Easy to use with results taking a period of time to really show up. Spreads before it's really known. So somebody might spread this microorganism, a lot of people get sick, and until somebody picks up on the fact that, hey, we've seen, you know, 24 patients in the last 3 hours that all have X, Y, and Z. It takes some time for it to really be known what's going on. And so the effects can be really devastating before we can start to recognize a problem and go toward a solution. So what can nurses do? Early recognition of a large epidemic. Large numbers of people seeking care from the emergency department or the doctor's office, people with high mortality rates, high risks. Some things like that would be smallpox, anthrax, the plague, hemorrhagic fevers, things of that sort. Pretty devastating. As far as disasters, know the evacuation route procedure for your facility. Develop the knowledge on your unit and your facility of the most likely biochemical agents that could be used. No backup systems for communication. I already talked about charting, paper charting. And what do you do to get extra staff in an emergency situation? What is that plan? Is there a phone tree, or do certain areas merge together and reduce staffing so the extras could go to a different part of the hospital? The performance appraisal process helps to shape a system's vision. How well is the team meeting the mission statement, etc. You want to identify how well a department objectives are met. Allow opportunity to make adjustments to the system or a unit model. This also serves as a controlling or auditing mechanism, which is useful in organizational prevention and corrective measures. It affects the internal and external factors for growth and profitability of the system. And there's guidelines for the process, including both negative and positive feedback. Immediate feedback in effort to fix a problem. It helps to recall a situation and decrease frustration. Frequent feedback from management motivates employees, and it helps them to continue working toward the goals and meeting the objectives, again, outlined by not only the department, but the system that they're working under. The appraisal process itself should be held in a private area to allow for negative feedback if there's some to be given, and avoid embarrassment or misconceptions. People get nosy and like, oh, why was Susie in the manager's office? That sort of thing. It's no one else's business. It should, again, be objective. And employees should listen and offer responses and feedback when it is requested, or when the manager is done providing the information. The process itself should be non-threatening. It shouldn't be intimidating. You should be able to freely speak during that time. Objectivity and consistency. Those things are thought of when we talk about something being legally defensible. Demotions of a person, failure to promote somebody, job elimination or termination. The cycle at which performance appraisals are done, that's a managerial's responsibility, beginning by determining tasks and priorities and outcomes for the position. And manager defines the functions, coaches and communicates the employee moving forward to success. Now, new employees usually have a 90-day appraisal, and all employees should have an appraisal about every 12 months. Or really, if there's a problem that arises within the unit or with the individual, it should there should be a performance appraisal after that event as well. These should be timely, and meeting time and place, again, should be interruption free. Employees should know what the system goals are prior to reviewing it. Stick to the facts. Okay, use direct and understandable language. Review and discuss goals, not only for the individual, but for the unit and the system as well. The appraisal should be based on the job description, the goals and objectives, an ongoing evaluation of the goals, input from multiple sources. You might have your manager say, I'm giving you my feedback, but we've also done peer evaluations, and this is what your peers say about you or think about your performance. Part of the performance appraisal process is typically the merit increase, and it's going to be based on the budget, money allocated at the beginning of the year by the system for each individual unit, and then that manager a lot of times has to determine who gets how much based off of their overall performance. Are they superior, exceeding expectations, meeting expectations, or below expectations, or maybe just not acceptable at all? Hopefully none of you will end up in that position. But the manager must look at an increase and position it within range. Want to ensure that there's internal pay equity, and look at the date of the last increase. And finally, with the performance appraisal, it shapes the system. The system's vision, reinforces constructive behaviors and discourages unproductive behaviors, develop and improve performances, provides input, improves quality, and it's a principal criteria for determining pay increase.